Alright, so now let's talk about conduction block. Now let's talk about a disturbance in the rhythm, arrhythmias. And one of the ways that the rhythm can be disturbed, besides the speed, besides the ectopic rhythm, besides the entrant rhythm, one of the other ways could be a block in the conduction system. Something is causing a block in the SA node, something can be causing a block in the AV node, and something can cause a block in the bundle branch or in one of its branches. Yes, the left bundle branch specifically has its own branches, and we'll come to that. They call them fascicles. We'll come to that in the next video. But for now, we're going to be talking about conduction block pertaining to the sinus block and the atrioventricular block. ممتاز? ممتاز. طيب. Now we're actually going to go to step number 5. Remember how we talked about step number 4, about assessing the sinus rhythm? Well, after you're done doing that, you're going to check for step number 5, which is check for any conduction block. You want to do it in order. First, look for any sinus block. Second, assess for AV block. Then there's 3 types: first, second, third degree, according to their severity. And then after you check for AV block, you check for the bundle branch block. So step number 5, we will check the conduction block. You check the conduction block from the sinus, no sinus, AV block, maybe. If not, check for the bundle branch block or the hemi block, which means a block in one of the branches of the left bundle branch. Again, we'll come to it in the next video. ممتاز? So that's in proper order. ممتاز? ممتاز. Now, I want you to take it as a principle. كقاعدة. ممتاز? Please take it as a principle. First of all, the conduction blocks, these blocks from their name, block in the conduction system, they can be combined. يعني, you might have a scenario in which you might have a first degree AV block plus a right bundle branch block. Or you can have a hemi block plus a bundle branch block. They call it a bifascicular block. So you need to keep it as a principle that just because you found first degree AV block, that doesn't exclude the others. You need to look for others because they can be combined. You might have both of these at the same time, all right, and vice versa. So that's one principle to keep in mind. Another principle you must also keep in mind with conduction block is if you find the second principle, if you find a bundle branch block, you cannot diagnose for hypertrophy of the ventricle. So if you find a bundle branch block, you cannot diagnose for left ventricular hypertrophy nor right ventricular hypertrophy. Because we'll see in the next video, not this one, we'll see in the next video, bundle branch block will affect the R wave amplitude, similar to the ventricular hypertrophy. So if you diagnose this case first, then you exclude hypertrophy, no matter what. ممتاز? No matter what. So that's why when we assess for left atrial enlargement, and specifically ventricular hypertrophy, you will keep it at step number 7. We will check this at step number 5, and then we will see if step number 7 is applicable or not for just ventricular hypertrophy. We'll start it in the next video. So there's 2 principles. Number 1, any of these can be combined, so they're not isolated, not necessarily. They can be combined. And the second principle is that if you find a bundle branch block first, you exclude ventricular hypertrophy. There, you cannot diagnose it. ممتاز? ممتاز. Right. Now let's talk about the conduction block. There's 3 types. What does block in the conduction mean? It means you either have a block in any of these areas. Any block that prevents the wave of depolarization going towards its normal route. ممتاز? طيب. Regarding sinus block, from the name, sinus block, this means that you have a block in the SA node. And if you have a block in the SA node, the SA node can't fire its action potential. So what would it look like? A peak QRST, a sinus beat, then suddenly a systole. No electrical activity, because where will there be QRS and T without the P wave, without the SA node? If you block it, none of the action potential, none of the wave of depolarization will continue its normal route. So you block the original site, or the origin site, you block the remaining depolarization. So sinus block will appear in the form of sinus arrest. And of course, in such a scenario, other pacemaker cells like in previous video, like ventricular pacemaker cells, they may see that the competitor is no longer there. So it will generate its own action potential, its own wave of depolarization to depolarize the ventricle. And if we see a bizarre and wide-shaped QRS complex that arises after a sinus arrest very late, then this is termed as escape beat. Or, other word, accelerated idioventricular rhythm. Accelerated idioventricular rhythm or escape beat, whatever you want. A bizarre wide-shaped QRS without any P wave. And this is life-saving because this is basically the pacemaker of the ventricle is trying its best to save itself since the SA node is no longer functioning. Mumtaz? Mumtaz. Now, let's continue. We finished the sinus block. Now let's talk about the remaining of this video. AV block. We have AV block from the name. We have a block that's arising from the either a block mainly in the AV node or a block in the bundle of His. Mumtaz? Either one. Mumtaz? Mumtaz. So we divide the AV block into first, second, and third degree according to their degree of severity. Mumtaz? Mumtaz. طيب. Now let's now look at each one. Mumtaz? Okay. Now we have first degree AV block. What is first degree AV block? It is a block in the AV node. And if you remember, the AV node, its purpose is what? Its purpose is to take the action potential. Mumtaz. It will take the action potential. It will wait around 0.1 millisecond conduction delay. Then after that, it will send this action potential or this wave of depolarization or this electrical current down towards the bundle of His, right? Then towards the right and the left bundle branch and so forth, right? But if we have a block in the AV node, then that means the conduction delay will be delayed further. That means the AV node, it will not transmit its action potential. It will be beyond 0.1 millisecond of delay. So the conduction delay of the AV node will be prolonged. It's not able to send its action potential downwards. Now, in case of first degree, this is not a complete block. You have a block, but eventually, the AV node will eventually send its action potential downwards. It's just what is happening is that in first degree, there will be a block that will prolong its physiological function of the AV node, which is conduction delay. So instead of 0.1 millisecond, it can be up to 1 millisecond, for example. So how would it look like on the EKG? Very simply, here we have a P wave, here's a QRST wave, and you can notice immediately the PR interval. Notice the PR interval, how it's prolonged. It is more than 0.120 seconds. If you remember, the normal range is between 0.12 to 0.20 seconds. If it's prolonged, this is first degree AV block. If it's shortened, less than 0.12 seconds, we'll see it in the next video, close Parkinson-White syndrome. But for now, in first degree AV block, when you have a prolonged PR interval and it's fixed, meaning what fixed? يعني, when I see a prolonged PR interval, it will not prolong further. This is the same distance. It's prolonged, but the same distance. Because if I look at this next sinus beat, it's approximately the same. There's still a prolonged PR interval in this one and in this one, but they're fixed. Mumtaz? And if you notice, even with a prolonged PR interval due to a delay in the conduction, further delay in the conduction, even though there's a delay, eventually, all the conduction will eventually reach the ventricles. All of this conduction from the AV node will eventually reach the ventricles. It's just prolonged. Mumtaz? So you have a fixed PR interval, and eventually it will be followed by a QRS interval. So a prolonged PR interval that's fixed, followed by eventually a normal QRS complex with a T wave. So all the conduction, as the rule, will go through the ventricles in first degree. Mumtaz? Mumtaz. Now let's look at second degree. This is worse than the first degree. In second degree, there's further block. Second degree AV block, there can be a block in the AV node, or there can be a block in the bundle of His. Now, in second degree, you will subdivide it into two types. Mobitz type 1, in some books they call this 1 Quebec block. Mobitz type 1, as well as Mobitz type 2, your subtypes of second degree AV block. Now, if we have a block in the AV node a little bit more than first degree, you'll have Mobitz type 1. In Mobitz type 1, you will have a prolonged PR interval. So concentrate. Here's a P wave, QRS, QRST, right? Concentrate. I want you to look at the PR interval. What is happening with each sinus beat? Look at this one. Look at this one. Look at this one. And now look at this one. What happened here? I'll tell you what happened here. What happened is the PR interval, it progressively lengthened. The PR interval, it got prolonged with each sinus beat. So this second one is more prolonged than the previous. And then eventually, it became so prolonged that now in the third beat, 1, 2, 3, this third sinus beat, it only has a P wave, but no QRS complex. Where's the QRS? Where's the T wave? I'll tell you what happened. Because of a block in the AV node more further than the first degree, that basically means that further and further block will cause further and further prolongation of the PR interval with every beat, to the point that the next beat will show what is known as a drop beat. What does a drop beat mean? It means when you have a P wave followed by no QRS. The QRS has been turned as dropped. There's no QRS. That means the block is so bad that now it will no longer depolarize the ventricles. So, in Mobitz type 1, you have lengthening of the PR interval with every beat. Every PR interval before it will be longer. So this one is normal, then it becomes prolonged, then it becomes prolonged till now you only have a P wave, followed by no QRS complex. Mumtaz? This is if there's a further block in the AV node, giving you Mobitz type 1. So there's lengthening of the PR interval followed by a dropped beat. A dropped beat, which means dropping of the QRS complex with only a P wave present. Mumtaz? Mumtaz. Now, we finished with Mobitz type 1. And if you're wondering, it will reset. Yani it will not just be asystole. Eventually, it will reset and you will have the same issue. Mumtaz? The same issue. Now, we finished Mobitz type 1. What about Mobitz type 2? What's the difference between this one and this one? Well, this one is the severe. This one is much more common, type 1. But Mobitz type 2 is the much more severe brother. This one is seen as diseased heart. Mobitz type 1, you can see it as a benign phenomenon. But in Mobitz type 2, this is the very serious one. This is the one that's seen in people with diseased heart. Why? Well, in Mobitz type 2, what you will see is very closely. Pay attention. P, Q, R, S, T. You have one sinus beat, and then you have this beat, and then you have this beat. We have like approximately 3 sinus beats, but I want you to concentrate. P, R interval is normal. So this one is normal, and then suddenly, the next beat just shows me a drop beat. What is going on? You just showed me a normal sinus beat. This is normal. And then the next beat, it showed me a drop. Suddenly, I have a drop beat. But where's the PR interval? It's not prolonged. It's not lengthening itself. And then the next one is normal. And then the next one, it shows another drop beat. So what's going on here? I have a normal sinus beat, then suddenly a drop beat. Normal, dropped. Normal, dropped. Normal, just P wave. Normal, just P wave with no QRS. So this is diagnosed as Mobitz type 2, in which you have an all or nothing conduction. All or nothing conduction with a fixed interval. What that means is the PR interval, it does not get lengthened. It doesn't get longer with each beat. It is fixed. However, it follows the all or conduction rule, in which all basically means you either have a normal beat followed by a drop beat. So that's the meaning of all or nothing conduction. You have a normal beat followed by a drop beat. All, nothing. All, nothing conduction. But the PR interval is fixed. It's not lengthened, it's not prolonged with each beat. Mumtaz. So that's the difference. So that's Mobitz type 2, the more dangerous type. And this one occurs, by the way, due to a block in the bundle of His. So this one I block in a bundle of His, the Mobus type 1, and a block in the AV node further than the first degree. So we finished up to that point the second degree AV block. So to summarize, first degree AV block, you have a prolonged PR interval, but it's fixed. And eventually, all of the conduction will reach it. Mumtaz, you will not see a drop beat. There's no drop beat. However, this is due to block in the AV node. Now what if we have a further block in the AV node? We have Mobus type 1, where there's lengthening of the PR interval with each sinus beat until eventually there will be a drop beat. Mumtaz? And in Mobus type 2, the more severe of the two subtypes, in Mobus type 2 for second degree, there will be a fixed PR interval. The PR interval will not be affected. However, there will be an all or nothing conduction. You have all, nothing. One normal sinus beat followed by a drop beat. One normal sinus beat followed by a drop beat. Mumtaz? So that's Mobus type 2. Now let's finish the video by talking about third degree AV block. The most severe, the most degree of severity. Mumtaz? Third degree AV block, the worst one. Now, Jama'ah, I want you to keep in mind, I want to summarize this another one more time. First degree, all the conduction will reach the ventricle. Even if you have a block in the AV node, eventually all the conduction will reach the ventricle. It's just delayed. In second degree, some of the conduction, some of it will reach the ventricle and some of it will not. But in third degree AV block, the most severe, no conduction will reach the ventricle. There will be no conduction of depolarizing wave reaching the ventricle from above, from the atria, from the supraventricular. No conduction. So what does that mean? What does the ventricle do in response? What will the ventricle pacemaker cell do? Since there is no wave of depolarization that will ever come from the ventricle from above, well, the ventricle pacemaker cell will function and it will generate its own wave of depolarization between 30 to 45. So this will depolarize the ventricle and thus produce a bizarre and wide-shaped QRS complex, right? While the atrium is fine. The atrium, yes, there's an AV block completely. There is a wall, a complete wall. I can draw a big X here, where there's a big wall between them. But the atrium here is working fine on its own because the SA node is sending action potential. But the problem is the action potential. The wave of depolarization is not reaching the AV node. It's completely blocked. So you have a wall here. So the atrium is fine. It will produce a P wave at its own regular rate from the SA node between 60 to 100. But the ventricles, they're not receiving this depolarization that's coming from this blocked AV node. So now the ventricular pacemaker cell is going to generate its own action potential. And it's going to produce a bizarre and wide-shaped QRS complex that's very inefficient, that takes very long to depolarize. And since it produces at 30 to 45 action potentials per minute, it will also be very slow. What do we call this? We have a condition here. What do we call this scenario in which the atrium and the ventricles, they have their own pacemakers. They work independently. They each have their independent pacemaker. What do we call this? Ladies and gentlemen, we call this AV node dissociation. AV node dissociation. They have no relationship with one another. The P wave has no relationship with the QRS. That right there, what I just explained, this is the characteristic feature you will see in third degree AV block, and you might see this in certain arrhythmias, such as ventricular tachycardia, to differentiate this from AV NRT with aberrancy. Alright? So, let's come to third degree AV block. Here, there is no conduction that will ever come to the ventricles. And there will be AV node dissociation as a result. So let's see what it looks like on an EKG. On an EKG, notice this is a P wave. This is a P wave. This is also 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 a P wave. We have a P wave here, 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 here. They occur at their regular rate. But now look at this. We have a bizarre wide-shaped QRS that also is working independently. And notice how with each bizarre wide-shaped QRS complex, they're much more slower. they much occur at a slower rate. The P wave is occurring at a regular rate. The number or the amount of P waves is greater than the amount of QRS because these P waves are operating at their regular rate. They're normal. So we have a P wave, P wave, P wave, P wave. But the ventricular rate that's coming from the pacemaker cell, they operate between 30 to 45. So they occur at a much slower rate, and hence they generate a lesser number of QRS complexes, which are bizarre and wide. And if you notice, they have no relationship with one another. The AV node, there's no P wave and QRS relationship. They each are occurring independently. Like you have a P wave occurring after it, you have a P wave that's over here, you have a P wave that's before it, you have a P wave that's after it. They are their own stuff. They have no relationship with one another. Because the atrium is occurring at their own regular rate, the ventricular are also occurring at their own independent rate, between 30 to 45, there's an AV node dissociation, and thus, with no conduction coming to the ventricles, you can diagnose this as a case of third-degree AV block, which is an emergency. You'll see this in cases where people have Lyme disease. People with Lyme disease may have a third-degree AV block, although reversible. So that's pretty much it for third-degree AV block. Now we have finished all of the conduction blocks regarding sinus block and regarding AV block. In the next video, we'll be talking about bundle branch block as well as hemi block. Mumtaz? Mumtaz.